Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you all to our first live educational session of the day titled Lymphoma 101 for Newly Diagnosed Patients. We appreciate that so many of you can join us online today. And before I introduce today's speaker, there are a few housekeeping items that I'd like to bring to your attention. So this session is being recorded and the recording will become available following the conference. Additionally, this Zoom software does not allow you to access video features or turn on your microphone. At the end of the presentation, we will try to leave a few minutes for questions, but you will have plenty of opportunities to ask questions throughout the next few days. And with that said, I would like to introduce our speaker. Joining us today is Dr. Joanne Brito, who is an assistant professor in the Department of Oncology at McMaster University and a hematologist specializing in the treatment of malignant blood disorders with a focus on the treatment of lymphoma, autologous stem cell transplant, and CAR T-cell therapy at the Juravinski Hospital and Cancer Center in Hamilton, Ontario. Dr. Brito's research interests include improving patient-related outcomes and quality of end-of-life care for patients with hematologic malignancies. So thank you so much for joining us today, Dr. Brito, and you can get started as soon as you're ready.
Thank you very much. Thank you to Lymphoma Canada for the invitation to present this session today, titled Lymphoma 101 for Newly Diagnosed Patients. These are my disclosures. So today we're going to talk about what is lymphoma, what's the definition, what are the potential causes of lymphoma, and to review the various tests of lymphoma. We will then go on to discuss how lymphoma is classified and the different staging tests that are used. And then we will discuss in using a broad approach to the different treatment options, just appreciating that you will have additional sessions going over treatments for each specific lymphoma subtype. So firstly, what is lymphoma? And in order to kind of talk about that, we need to understand where the disease originates, which is in the lymphatic system. So the lymphatic system is an important component of our immune system, and it's the circulatory system for our body's immune response. It is composed of multiple different types of things. So firstly, the lymphocytes or the lymphocytes or cells, and then you have the lymphatic fluid, which circulates in the lymphatic system or vessels, just like your blood would circulate in your blood vessels. And the purpose of lymphatic fluid is to travel throughout the body, to go in and out of the lymph nodes and other lymphatic tissue, and to deliver lymphocytes or the cells to areas where you might need an immune response. The purpose of the lymphatic fluid is also to clean up after those cells and the lymphatic cells or lymphocytes that have also died, to clean those up. And so what are lymphocytes? Lymphocytes are white blood cells that fight disease-causing organisms like bacteria, parasites, and various fungal infections. And you have three types of lymphocytes that originate from the stem cell. Most people will have heard of stem cells. They're the little like baby cell out of which you get specialized cells that develop. And so today we'll be focusing on these three cells highlighted here in red. So your B lymphocytes or your B cells are responsible for antibody production. Your T cells defend against infection and control the body's immune response. And your NK or natural killer cells are the ones that attack and destroy the infected or abnormal cells. So normally your cells will grow and multiply, and it's a very tightly controlled and organized fashion that growth and division happens. The cells are programmed in a way to grow and behave in a certain way and multiply or die at certain times. And there are many checks and balances that happen to make sure that the cells develop and grow and multiply and die in the right way. But when you have cancer, you have damage or mistakes that happen in different blood cells, and that results in abnormal or uncontrolled growth of cells. In lymphoma, the uncontrolled and abnormal growth happens in your T cell or your B lymphocytes. Many of our patients, of course, want to know what caused their lymphoma to happen. And for all cancers, there may be certain lifestyle factors that are known to contribute to the development of cancers, or environmental factors like smoking or sun damage or excessive alcohol consumption, or even sometimes you can have certain genetic mutations that run in families. But for some cancers, and certainly like for some lymphomas and CLL, we don't really know what causes them. There are some risk factors that have been identified, but many people with the same risk factors do not go on to develop lymphoma, while others who have no risk factors may go on to develop lymphoma. And some of these risk factors might include, like, for example, if you've had the Epstein-Barr virus, or the virus that causes mononucleosis or mono, or if you have HIV, or if you have an autoimmune disease or a weakened immune system after a organ transplant, or if you have a parent or a brother or sister with a personal history of lymphoma, some of these risk factors that can go on to cause lymphoma. But just remembering that many people have one or more of these risk factors and don't go on to develop lymphoma, and you may have none of those risk factors and still go on to develop lymphoma. So what are the signs and symptoms of lymphoma? So usually patients will notice an abnormal lump or bump in their neck or their armpit or their groin. Sometimes their abdomen might feel enlarged and they might have difficulty finishing a meal from getting full really quickly. That's often a sign that the spleen is enlarging and pushing on the stomach. There are some red flag symptoms that patients can experience, like unexplained fevers in the absence of an infection, or night sweats that are drenching. So in patients with lymphoma, those types of sweats would cause you to need to change your pajamas or sheets in the night. And then weight loss, so unintentional weight loss where you lose more than 10% of your body weight in the preceding 3 months. That would raise suspicion for lymphoma. These, of course, are all non-specific, which means that they can be seen in conditions other than lymphoma as well. And then sometimes in advanced cases, you can get symptoms from compression of an organ or an organ structure. So, for example, if you have swelling in the legs because of compression from your lymph nodes in the groin, which causes impairment in the ability of lymphatic fluid to return back up from the legs. Or if you have a large lymph node mass that's compressing on the kidneys, you might have impaired kidney function. I do want to briefly just touch on lymphocytic leukemia, which is when the abnormal lymphocytes have grown and replicated primarily in the blood and the bone marrow. So on the right here, you have a blood smear that when you look under the microscope, you can see all the normal pink blood cells, and then an abnormally high number of these blue cells, which are your mature lymphocytes. There's just too many of them. And some lymphomas are more likely to involve the blood and bone marrow and less so the lymph nodes, but there is a lot of overlap in lymphomas that can present with both. So how do we diagnose lymphoma? So we can suspect it based on a patient's symptoms and physical exam findings, like an enlarged lymph node in an area that we can palpate. And then we can go on to do imaging scans like a CT scan or an ultrasound or an MRI, which might be done in someone to investigate a physical exam finding, or sometimes they can be done for other reasons and then show findings that might raise the suspicion for lymphoma. There are also some blood tests that might make us suspect lymphoma, like a high lymphocyte count in the blood, and sometimes other markers in the blood that tells us there is a very rapidly dividing group of cells that can show up in the blood. But a definitive diagnosis of lymphoma always requires a tissue biopsy or sometimes a sampling of fluid, which is then examined under the microscope. The best biopsy is one that takes a large amount of tissue, like multiple core biopsies, or even better yet, an excisional lymph node biopsy where the entire lymph node is cut out. And the reason why we need that is it's actually two reasons. One is that the more tissue you have, the better you can see and appreciate the full architecture of the lymph node. And this really helps in determining whether you have lymphoma or whether the proliferation of cells is just in reaction to something else, like an infection or inflammation. It also helps when you have lots of tissues, it helps us to do many of the specialized tests that are required to make an accurate diagnosis of the subtype of lymphoma. And that is crucial to the decision making in terms of how you go on to treat. Sometimes the lymph node can be in an area that is not accessible to a biopsy. And so then we may need to look in other places like the bone marrow, which is the factory that makes all your blood cells, or the blood. But really, the best place for a definitive diagnosis of lymphoma is lymph node tissue. So here on the left, you have a normal lymph node that shows the cell architecture, which is how the cells are arranged in the lymph node into these different regions or zones. And then on the right here, you have a cancerous lymph node where the normal architecture of the lymph node is disruptive by sheets and sheets of these abnormal or malignant lymphocytes. And you get a loss of the architecture and a loss of the normal different zones of the lymph node. Then the pathologist will go on to do many special stains to identify the different cells that are in the lymph node in order to identify the specific lymphoma subtype. So how is lymphoma classified? There are many different kinds of lymphomas. So typically we will break them down into Hodgkin's and non-Hodgkin's lymphomas. And this diagram only really gives a few of the most common subtypes. These classification systems are constantly evolving as we come to do more research and understand more about the biology of lymphoma. So within lymphoma, you have Hodgkin's lymphoma, which is, usually about 10 to 15% of all lymphomas. And then you have classical Hodgkin's lymphoma, which is the vast majority of Hodgkin's lymphoma. And then this much more rare subtype, which is nodular lymphocyte predominant Hodgkin lymphoma. And then within the non-Hodgkin's lymphoma category, we break that down further into B cell, B cell being the vast majority non-Hodgkin's lymphomas, and then T cell being the more rare kind. And then within the B cell category, we split those up further to indolent or aggressive. And the indolent non-Hodgkin's lymphomas are very slow-growing variants, the most common of which are CLL and follicular lymphoma. And then you have the more aggressive or fast-growing non-Hodgkin's lymphomas, of which the most common is diffuse large B-cell lymphoma or DLBCL. And then within the T cell category, you can have different categorizations even further depending on where the T cell lymphoma mostly presents. So you can have ones that mostly are in the blood, so they're called leukemic variants, or sometimes they can be largely in the skin, like cutaneous T cell lymphoma or mycosis fungoides, or sometimes they can be in the intestines or the lymph nodes. So it's very important to know which subtype of lymphoma you have, because all of the treatments that we use for lymphoma are really dependent on the type of lymphoma that we are dealing with. So what tests do we do once we have made the diagnosis? So the first thing is to stage the patient, which helps us to determine not only the prognosis of the patient, but also helps to determine sometimes can help us determine the treatment that we use, as it can be different if the lymphoma is in a more advanced stage. So most patients will have already had a CT scan done by the time they come to their lymphoma team in order to have made the diagnosis. But we can also use CT scans to stage, although now we are increasingly using a more specialized type of CT scan called a PET scan, which I will come to shortly. So a CT scan is like having thousands and thousands of X-rays produce this unified image that looks like this. So for example, the first image here is showing the chest with a mediastinal lymph node mass. And then here you have the chest and the abdomen also showing some abnormal lymph node or masses. And so I mentioned that now we are increasingly using PET scans to stage patients, especially for Hodgkin's lymphomas and the more aggressive non-Hodgkin's lymphomas. So PET scans are, they use a harmless radioactive tracer that's linked to a sugar molecule that is metabolically active, that is taken up by metabolically active or growing tissue as like a source of their fuel. And then when the radioactive tracer is taken up, it lights up on the image here, and namely here, you see it lighting up in orange. So lymphoma is a type of metabolically active tissue that will take up the sugar and the radioactive tracer and light up on the scan. But this is not specific to lymphoma. Other tissues can be active and take this up as well. Like the brain, for example, is very metabolically active. And so it can light up on a PET scan, but it doesn't necessarily mean that there's lymphoma there. You can also, if you have an infection or some kind of inflammation in a tissue, that can light up on a PET scan. So you can imagine if, it can be quite non-specific, and especially if someone has diabetes and their sugars are not under control, you can see a lot of non-specific uptake in different areas. It doesn't necessarily correspond always to lymphoma involvement, but if a patient is otherwise well, is their sugars are under control, if they have diabetes, they don't have infection, an active infection or an active inflammation condition, then a PET scan can be very useful in staging the patient. PET scans are now standard of care for baseline staging for Hodgkin lymphoma and in the aggressive non-Hodgkin's lymphomas, and they can also be used to assess response to therapy in between treatment cycles. For the indolent non-Hodgkin's lymphoma, they are being used more and more frequently, and they can also be used to answer specific questions in the staging process. Like maybe there's an area that is behaving more aggressively and may require a PET scan to help delineate that. Sometimes you may need additional tests to complete the staging process. So sometimes this might mean a bone marrow biopsy. They're not typically being done now in the era of PET scans because a PET scan can also show if the bone marrow is involved. But if someone has unexplained low blood counts, it may still be required to do a bone marrow biopsy at diagnosis. And then a lumbar puncture would be done to see if there is any lymphoma cells in the fluid that surrounds the brain and the spinal cord. Both of these are day procedures. They can be done by the lymphoma team in the clinic. And also, and although they can be quite anxiety provoking, they're actually typically quite well tolerated. So we use a combination of those imaging tests and maybe some of the additional tests to stage a patient, which refers to how much of your body has lymphoma in it and where the lymphoma is. So in stage 1 is when you have one lymph node area involved with lymphoma. Stage 2, you may have 2 or more locations involved, but both are above the diaphragm or both are below the diaphragm, but they're on one side of the diaphragm. And then stage 3 is when you have 2 or more lymph node areas involved, but they're on opposite sides of the diaphragm, and maybe can also include the spleen, which is one of those lymphatic organs. And then stage 4, which is the most advanced stage, is when you have cancer outside the lymphatic system. So maybe it has spread to the liver or the lung or the skin or the bone marrow. We also use other designations sometimes if patients have those red flag symptoms like unexplained fevers or drenching sweats or weight loss. Those are called B symptoms. So we designate A for no B symptoms, or B if B symptoms are present. And then E if there is extension from a lymph node into somewhere else that is directly adjacent to the lymph node area, or X if there's particularly large lymph node mass. For lymphoma, it is quite common for lymphomas to be more advanced stage at diagnosis, just given the nature of the disease and the lymphatic system being dispersed throughout the body. It's obviously very easy for lymphocytes and abnormal lymphoma cells to spread throughout the body. Stage 4 does not in and of itself portend a poor prognosis compared to other non-blood cancers. So we also need to do other tests in order to then determine a patient's ability to tolerate the treatments that we use in lymphoma. Especially a lot of the treatment options can have some deleterious impact or damage to different tissue, different organs. So we would want to make sure that the kidneys and liver are working well, which is typically assessed by blood work, and that the heart function is good, which is typically done by an echocardiogram, which is an ultrasound of the heart, which shows us how well the heart pumps. We may also want to do pulmonary function tests to assess how well the lungs exchange oxygen, how well they expand. And then there are other tests to ensure that patients don't have any lurking or dormant infections, just because chemotherapy is very immune suppressing, and so it can reactivate dormant infections. So typically your hematology team or your lymphoma team will check universally for hepatitis B and C and HIV at the time of diagnosis. So how is lymphoma treated? So like mentioned previously, our treatment approach really depends on the subtype of lymphoma you have. And again, I will go over this in a very broad sense because the subsequent sessions are tailored to the specific subtype of lymphoma. So we break it down into the indolent non-Hodgkin's lymphomas and then aggressive non-Hodgkin's lymphomas and Hodgkin's lymphoma, which typically behave in a moderately aggressive fashion as well. So the indolent lymphomas are slow growing typically and thought to progress over a number of years. They are generally thought to be incurable, and so patients don't always require treatment, especially at the time of diagnosis. So I like to use a lawn mowing analogy where at some point in the disease trajectory, you may need to mow the lawn, meaning treat the lymphoma. And then slowly over time, the lawn may grow back, and at some point, you may need to mow the lawn again. But the lawn is always there, it's never gone away, meaning the disease is incurable. On the contrary, the aggressive non-Hodgkin's lymphomas and Hodgkin lymphomas will progress over a period of weeks to months, and they are fatal over that period of time if left untreated. So they typically require urgent initiation of treatment and are potentially curable with treatment. And the lymphoma treatments really can involve multiple different things that can be used either in isolation or in combination. So some patients may go on to just be monitored, watchful waiting or active surveillance. Others may go on to have chemotherapy and or radiation therapy with a combination of immune therapy. Some patients might have targeted therapy, especially if they don't tolerate necessarily chemotherapy drugs. And then some of the more advanced therapies in lymphoma treatment is stem cell transplantation. So systemic therapy or chemotherapy is when we use a combination of intravenous chemotherapy drugs and or oral pills, which are typically steroids, given together at pre-specified doses and at pre-specified timed intervals. And these are administered at specialized cancer centers. And there are many side effects, but they are specific to each drug in the regimen. Immune therapy is a type of therapy that really harnesses the body's own immune system to kill the cancer cells. And often these immune therapy drugs are used in combination with the chemotherapy. So you might hear, for example, the drug name rituximab. That is a type of immune therapy that is used in combination with some of the chemotherapy drugs that we use to treat various lymphomas. And then there is radiation therapy, which uses high energy external beam X-rays or radiation to kill cancer cells. And lymphoma cells are uniquely sensitive to radiation treatment. It can be used on its own, but more commonly, it is used in addition to chemotherapy or at the very end of chemotherapy. And it's typically delivered over several sessions over several consecutive days. For patients with relapsed lymphoma or lymphoma that has been refractory to chemotherapy, we will typically go on to administer some kind of cellular therapy. And usually this is using, again, the body's own cells for certain purposes in lymphoma treatment. And usually this is some kind of stem cell transplant. So either an autologous stem cell transplant, which is uses the word autologous, which means you're using a patient's own stem cells, or an allogeneic stem cell transplant where you're using a donor's stem cells to treat the lymphoma. And then we get to the most specialized type of cellular therapy called chimeric antigen receptor, or CAR T cell therapy. And again, this is used in the relapsed or refractory setting where patients have not responded, or where patients' lymphoma has not responded to the chemotherapy we used initially. And here, this type of therapy uses the patient's own T cells. They become genetically modified in a lab where a gene is inserted into the T cell to make the T cell recognize the cancer cells or recognize a protein that is expressed on the surface of the cancer cells. And then those T cells are infused back into the patient, and then the T cells will expand, will recognize the cancer cell, and kill the cancer cell. So again, you're using the patient's, you're harnessing the power of the patient's own immune system to recognize and kill cancer. And then, like I mentioned initially, so for some indolent or slow-growing lymphomas, especially in patients without symptoms or with any worrisome or concerning features, we may go on to just watch these patients carefully, or through an active surveillance manner. And that's because research has shown us that treating these patients earlier does not necessarily end up in better outcomes for the patients, and may be exposing patients unnecessarily to the toxicity of the drugs that we use. So usually active surveillance will mean close monitoring by the hematology team every 3 to 6 months with a history, a physical exam, and blood work to determine kind of if the patient is stable enough to continue with active surveillance, or if at some point they have reached the stage where they may need to initiate treatment. And so I do want to quickly touch on this aspect of prognosis, which is when patients ask us, well, how well will my lymphoma respond to the treatment, or how long do I have? And usually my answer to this is, it depends, which is not not particularly helpful, but really it is such a multifactorial concept, and many things contribute to our assessment of a patient's prognosis. A big part of it is the lymphoma subtype, the stage that they're at, a diagnosis, the type of treatment that we use, and then the response that the patient has to the treatment. We can use certain prognostic indicating scores, like this scoring system called the IPI, or the International Prognostic Index, that puts these different factors like a patient's age, their stage, some of their blood work indicators, and how many areas of the body were involved with lymphoma. And it comes up with a score that then tells us, okay, this patient has an X% of likelihood for overall survival, or survival in the next 5 years. So what are the take-home messages from today's session? So number one, diagnosis of lymphoma requires a thorough history, physical examination, blood work, imaging tests, and biopsies. There are many, many subtypes of lymphoma, and knowing your subtype is key to understanding the treatment options available and the prognosis. The treatment or therapy landscape continues to rapidly evolve and is becoming more individualized. But the key to all of this is for you to always ask questions of your hematology team to continue to remain informed and empowered throughout your disease trajectory. So with that, I will end my presentation and I'd be happy to answer any questions.
Thank you, Dr. Brito, for that great presentation, setting the tone for all that's to come in the coming few sessions over the next few days. And as a reminder to the audience, at this time, you may submit questions in the chat box, which is in the middle of the black toolbar at the bottom of the screen. We will try and answer as many questions as possible, as we do have some time before the next session starts. So one question that came in was, if there is extranodal extension into the spinal canal, once treatment removes the tissue, are there special considerations for follow-up assessments or care?
So I'll just repeat that. So if there is extranodal involvement in the spinal canal, so for example, there may be lymphoma cells within the central nervous system, then we would use treatments to kind of clear the central nervous system. And subsequent monitoring, it depends. Some people might want to do lumbar punctures to monitor that there is no ongoing involvement in the central nervous system. But I would think the vast majority would only repeat lumbar punctures if there is repeat in symptoms, for example, or new onset of symptoms or recurrence of symptoms, just given the invasive nature of lumbar punctures.
And one question came in regarding classification. So can you please explain more in depth the differences between an indolent non-Hodgkin's lymphoma and an aggressive non-Hodgkin's lymphoma, and if there's any differences in genotype, phenotype, or just in their tissue microenvironments overall?
Yeah, it's a good question. So the indolent non-Hodgkin's lymphomas are typically those slow-growing ones that are thought to grow slowly over a period of many years. And initially, like the thought is that patients may not even come to attention at the onset of those lymphomas. So it's usually when they have grown or spread to a stage that they're causing symptoms that they come to diagnostic attention. So typically they will end up being more advanced stage at the time of diagnosis. Just when they're earlier stage, you might not pick it up. In contrast, you have the aggressive non-Hodgkin's lymphomas that are actually quite different from the indolent ones. They are different in their genetic makeup. They are different in their biology. They are different in their behavior, and they are different in their prognosis as well. And they typically they are life-threatening and if not treated within a period of weeks to months, as opposed to the years that is usually the indolent disease. The indolent non-Hodgkin's lymphomas, they are thought to be incurable. So they are very responsive to treatment, but they may never go away completely. Whereas the goal of treatment typically for the aggressive non-Hodgkin's lymphomas is still for cure. There is curative potential in those. Yeah, I hope that adequately answers the question.
And thank you for that response. Moving on to the next one, how do we know if we still have signs of lymphoma in the body after stem cell transplant, as I still get night sweats and hot flashes?
Yeah, again, those symptoms of lymphoma are non-specific, so they can be from other things as well. So it's not always easy to tease out necessarily that it may be 100% related to lymphoma or not. The best way to know whether there is remnant lymphoma after a stem cell transplant is when we do the imaging scan, typically a PET CT or a CT at a period of time after the stem cell transplant, sometime between 30 days to 6 weeks after the transplant, we will do a scan to check what the response was to the stem cell transplant. And after that, if you're still having worrisome symptoms and there is concern, there may be a role for another scan down the road to monitor.
Okay. And we received a few questions in relation to transforming of a lymphoma to another type.
Yeah.
And so can you speak, first of all, can this happen? And when it does, how often and what causes this transformation?
That is a very good question. So typically about 10 to 15% of the indolent non-Hodgkin's lymphomas can go on to transform to an aggressive non-Hodgkin's lymphoma. And I don't think there is really a known cause for it. It again is related to genetic mutations, disruption in the DNA, which then, again, it disrupts that checks and balances that we have for cell growth. And so if you just get that right type of genetic mutation or mistake, you can flip from the indolent to the non-Hodgkin's, to the aggressive non-Hodgkin's lymphoma. So 10 to 15% of the slow-growing ones will go on to transform to the aggressive ones. The idea then, when you do get a transformation, is that you have now got two lymphomas. So because those indolent non-Hodgkin's ones are incurable, they are always underlying. But now you have the aggressive one on top of it. And though that aggressive transformed disease needs to be addressed in an imminent fashion, usually needs treatment right away. And there may be additional treatment that's delivered to targeting the underlying slow-growing non-Hodgkin's as well. But the idea is that you have both, but you're aiming to cure the aggressive one while also, kind of mitigating that the slow-growing one as well. But the thought is that the slow-growing one will never go away completely.
Okay, and the next question is more situational based. So the question states, I am 25 and have a small lump on my neck/collarbone. An ultrasound and blood work raised no concern and came back as normal. I'm afraid that I'm going undiagnosed with some condition or that this is the start of something, possibly lymphoma. What should I do as I have no other symptoms?
So yes, that is very situational. And I think the best thing to do would be to talk to your healthcare provider about your concern about going undiagnosed. There are certain features on an ultrasound of a lymph node that raises suspicion that the lymph node is abnormal. There is a fatty part of a lymph node that, if that is lost on an ultrasound, on an ultrasound image, it raises more of a concern. Whereas if someone still has preservation of that fatty hilum, then it says, okay, well, that lymph node is probably just a normal, but it's slightly enlarged lymph node. We all have lymph nodes. Some of them might be able to be felt, and that doesn't necessarily mean that they're abnormally large, and it certainly does not always mean that you have lymphoma. Lymph nodes can be enlarged because of other things and other conditions as well. So it does not necessarily mean that you have lymphoma. The only way to know definitively whether or not you have lymphoma is to take a biopsy of that lymph node.
Okay. And another situation-based question. So how important is it to complete the chemotherapy treatment? In my case, I've completed 11 rounds and I'm debating about the 12th one. I was diagnosed with stage 4 Hodgkin's lymphoma, but declared in metabolic remission after 4 treatments.
So it is actually exceptionally important, if you can tolerate all the treatment cycles, to complete all treatment cycles. And that's because the number of rounds of chemotherapy is not arbitrarily determined. It is actually carefully studied in large studies, whether it's randomized control trials or other more observational studies. This is very carefully considered as to the optimal number of rounds of chemotherapy that will lead to the prognosis that we come up with. So, or that would lead to the optimal outcomes. So I would say if you have tolerated it well, then it is prudent to complete all the chemotherapy cycles, just to give yourself the best opportunity for complete remission or cure.
And we have time for one last question for today, for this session actually. Should or does blood work regularly include items that are used in calculators for prognosis of non-Hodgkin's lymphoma?
So one of the pieces of blood work that is used in monitoring after you have completed treatment is this LDH, which is a component of the IPI. But purpose of that blood work in monitoring is separate from the prognostic indicator, because prognosis is done at the time of diagnosis or at the time of treatment, whereas the monitoring blood work is done to monitor. So yes, there may be some overlap in the tests that are used, but not typically, not for the same purpose.
Okay. And just because there's so many questions in the chat, I'm just going to take one more. This is a question that comes quite often. I've received a lymphoma diagnosis from my doctor, but need some reassurance before deciding on treatment options. How can I get a second opinion?
So again, it's a question of speaking to your healthcare provider and seeing if there would be if they would be willing to provide a second opinion, either from another hematologist at the same site or from a hematologist at a different site. It also depends on the nature of the additional information that you are seeking, whether it's, whether you are questioning the diagnosis, which might then require a separate pathologist to review the biopsy, or if you are questioning the different treatment, or if the desire for second opinion is based on additional information about treatment options, then or clinical trials, for example, that are available at other treatment centers, then it would require a conversation with a hematologist at another treatment center. Really, the answer to that question is to speak to your healthcare provider about your desire for a second opinion and why you would like a second opinion.
Thank you, Dr. Brito, for taking the time to answer those questions. I will say there are many, many questions coming in the chat, but I do want to let you know that there will be ample opportunity to ask your questions. Specifically tomorrow, we have designated Q&A sessions based on subtype, so that we're able to take that time to answer your questions. And with that said, I do want to now direct the audience to attend the next session titled Infections, Vaccines, and Immune Health During Treatment. Thank you, and I hope to see everyone in that session.